There is a reason to worry about acute heart failure because it's, despite seeing a decrease in mortality for chronic heart failure, we see that patients with acute heart failure and those hospitalized for acute heart failure have a significant mortality over the 1 year follow-up. That is around 35%, as shown by the heart failure survey. And if we look at the death, hospitalization, and visits, so the occurrence of cumulative events, we see that even with recent trials with, say, the dose of CARRESS-HF, that is a 40% occurrence of events. And these, I mean, just mind that these are different scales, but so it's 40%. 40% at 60 days. So it's a significant burden. So, but if we look at the more evidence-based guidelines that are the European, the guidelines of HFA and ESC, you can clearly see that you barely see any 1A recommendation. You see at the most 1B or 1C, and the only recommendation for 1A is the thromboembolic prophylaxis in patients who are not anticoagulated. For the rest, we don't have any evidence of any effective treatment. So we treat most of our patients on the basis of historical benefit of drugs. So basically, we don't have much of an evidence. So for intravenous nitrates, the efficacy is still uncertain. The same for levosimendan, for omecamtiv, and the same for ultrafiltration. We have still drugs in phase 3. These are Relaxin, that is in the second phase of his phase 3 trials. I will report to you the RELAX-AHF, but the RELAX-AHF has been extended to RELAX-AHF 2 and TrueHF. But one of the trials that has been presented at the end of 2012, so I mean it's just in the border with 2013, is the dose study. This looked at whether there was any difference in administering a bolus administration or continuous infusion of furosemide in patients with acute heart failure, and whether there was any difference in a low intensification, so doubling the oral dose, or high intensification, so increasing the dose by 2.5-fold. And as you can see, I mean, this effect can be magnified because it's expressed as area under the curve, but actually the difference was 3 millimeters. So 3 millimeters over a vast scale of 10 centimeters basically is nothing. So there was no effect on on dyspnea, on the visual analog scale, and there was no effect on the change in creatinine. So basically there was no effect whether you give it the diuretic either as a bolus or as a continuous infusion, or whether you increase the dose as doubling the dose, or you increase the dose by 2.5-fold. And this basically is based on physiology, because there is evidence that patients are different, and different patients respond different to diuretics. There are some patients who may reach earlier the diuretic threshold, and there is some kidney resistance to diuretics, and therefore you need higher doses to overcome the diuretic resistance. So the effect is not whether you give a bolus or you give a continuous infusion, or whether you have one single dose, but it's how you adapt the dose to the single patient. The other dose was the effect. The other study was to assess whether the ultrafiltration was effective in patients with heart failure. We have heard about it yesterday from our chairman, and basically in the CARRESS-HF, ultrafiltration was compared to intensive pharmacological therapy. As you can see, they gave similar reduction in weight loss. The creatinine increased a little bit more with ultrafiltration, while it didn't change with pharmacological therapy. And as you can see over here, on the time course, with the mean change from baseline in serum creatinine, the serum creatinine decreased from the beginning with pharmacological therapy, while it initially increased with ultrafiltration and then decreased, while body weight had a stable decrease with both therapies. So basically, it is again a mean of adapting therapies and to use ultrafiltrations, as we heard yesterday from our chairman, to patients who need the different therapies. Interesting evidence is coming from the use of the natriuretic peptides. We know about ANP and BNP, and also we have the Ularitide. Ularitide is Ularitide, is produced by the kidney as a hemodynamic effect, induces venous and arterial vasodilation, has also an effect as bronchodilation, has an effect as a hormonal effect, as reduces the renin-angiotensin-aldosterone system, decreases endothelin, and at the kidney level increases diuresis and increases natriuresis. Early studies with Ularitide have shown that as an effect on pulmonary wedge pressure, significantly reduces wedge pressure, and the phase 2 studies have shown that the 15 nanograms per kilo per minute seems to be the effective dose to be tested. Now, the TRUE-HF is a study that is ongoing. The trial protocol was published last year, and this is the first study in the first phase 3 trial in heart failure to be specifically designed to assess the effect of early treatment on cardiovascular mortality as an endpoint. Basically, it will be testing the effect of Ularitide versus placebo to be infused within the first 48 hours of hospitalizations. Will be conducted in 190 centers in US, Europe, and Canada. As an adaptive type of design, it will include 2,152 patients that can be extended to 4,000 patients, and after an interim analysis. And the primary endpoint is a combined endpoint, is a composite score that assesses symptoms and clinical course of patients during the 48 hours, and then the cardiovascular mortality following randomization for the entire duration of the trial. Basically, this is a trial that looks similar to the RELAX-AHF. RELAX-AHF was based on the effect of serelaxin on serelaxin, that is a molecule that is an hormone that is produced during pregnancy. It is a molecule that has antioxidant and anti-apoptotic property. Basically, is a substance that has been tested in a wide range of diseases that went from sclerodermia to heart failure to all possible diseases, and at the end they tried to test it in heart failure, and they tested in the RELAX-AHF in 1,100, a little bit more than 1,100 patients with a systolic blood pressure more than 125 millimeters of mercury in the first 48 hours from admission. As you can see, there was no effect on the VAS scale, and the Likert scale, that was the other scale assessing dyspnea, didn't change over time in these patients. And this was the primary endpoint. There was the dyspnea relief with the Likert scale. As you can see, no effect whatsoever on the Likert scale, and no effect on the secondary endpoint, that was death or rehospitalization at day 60. So cardiovascular death was not affected. There was no effect on rehospitalization. Despite that, there was an interesting observation, and the interesting observation was that at day 180, there was a trend, or I mean, we should call it a trend, because there was a lot of loss at follow-up. I mean, the company calls it a significant reduction in mortality. But however you want to call it, there was a difference between the two groups in mortality at 180 days and a reduction in mortality and hospitalizations. So this prompted the EMEA and the FDA didn't approve the drug, because this is a post-hoc analysis and there was a lot of lost follow-up. But this prompted the Novartis to start RELAX-AHF 2, that is a trial that is currently ongoing and is testing whether Relaxin will be effective in reducing mortality at 3 months in patients with heart failure. Now, just to report a few other trials that have been conducted in completed in 2013 and 14, there was another trial looking at low-dose dopamine or Natriuretic on renal function in patients with heart failure, and as you can see, the two strategies were not effective in improving renal endpoints, neither of them. One interesting study was the COACH study recently reported by Ralph de Boer that basically looked, is not strictly speaking acute heart failure. I mean, these were patients who were discharged on spironolactone, so it's more in the late phase of the acute heart failure. But what they found was that patients were discharged on spironolactone had a significantly better survival than patients who were not discharged or not on spironolactone. And again, another negative Natriuretic trial. So at the end, we have a lot of negative trials, and we still are with the indications from the European Society of Cardiology with just one 1A indication. I think that we still need to see a nice positive trial. There is promising data from Ularitide, but probably what we need is a trial with a drug that changes completely the way of thinking at acute heart failure. Thank you very much for your attention.
Thank you, Professor Rosano, for a very nice coverage of the trials. Any questions?
Give the microphone, please. Okay.
Despite higher mortality in acute heart failure syndromes, why we lag behind decades of starting or initiating trials in acute heart failure? Any specific reason?
I think that there is a lack of understanding of the mechanism. You know, there is a lack of finding a different approach, like what we did with thrombolysis in acute myocardial infarction. I just take you to the example. There has been a breakthrough in the treatment of Clostridium difficile infection. That is a deadly condition where 98% of people die. And we've been treating that with antibiotics. And despite that, 98% of people die. Now there's been a new treatment that is the fecal transplantation, and 95% of people survive. So you see, it's probably is the way of thinking at the treatment of heart failure that is wrong. So we probably need to find something, a different approach. And probably the approach that we are using, it's wrong. And Ularitide seems interesting because it's a multimodal approach, but it's, again, it's not, I don't think is going to be a breakthrough.
Yes, another question.
Any trial is going on liver in the heart, like cardiohepatic syndrome, because multi-organ failure is the main problem in acute heart failure syndromes. So anything done on the liver in the heart? Because cardiorenal syndrome is well described, but the cardiohepatic, which is the main problem in acute decompensated heart failure, but it's not well looked after.
Yeah, not that I'm aware of. And the other problem is that so far the main problem with the trials in heart failure is that we are we are concentrating on the first 48 hours, and what we're lacking is while trials in chronic heart failure are conducted in patients who are 3 months after the acute event. So we are lacking also trials after the 48 hours and within the 3 months. So we need a plan after the 48 hours at discharge until an optimization of therapy. That is something else that we will need, but not I'm not aware of any other trial.
Excuse me. Any more questions?